Ma'am, live started. 1 minute, I will start recording. You can start, ma'am.
Hello, everyone. I'm Dr. Nawal Mohammed, here again on the platform of Auricle. Uh, to begin with, we'll have a class today on complications of suppurative otitis media. Before that, I'll just give you a very small introduction to our platform. We have Auricle, a platform where we teach students for their academic exams and also prepare them for their next exams. So we have rapid revision of all important questions. We have volatile facts. We have quick revisions. High yield topics will be here and most expected topics will be covered. So today we'll have a topic, a long essay and a short essay. So we have two short essays, difference between safe and unsafe chronic suppurative otitis media. We had a very small discussion about this topic in our previous class. Today, we'll just have a deeper dive because this is a very important topic for your academic exam and also for your clinical exams. And the second short essay will be tuberculosis otitis media. And long essay will be chronic suppurative otitis media. Otitic barotrauma, we have covered it in the previous class, but I will give you a brief about it. And we'll have non-suppurative otitis media. That will be the important topic today. So why do you have to choose Auricle? So Auricle, we have live recorded classes, we have live classes, like we have now, we have practical sessions, we have exam modules, and we also have a hard copy book set. So in recorded classes, we record all the classes, all the questions that are covered in the exam from previous last 10 years of question papers. And we keep it in a recorded form in the application so that you can come anytime and you can review or you can review that video again and again every time you want to clear the concept of that specific topic. Now, live classes are where we cover the topic in depth. We have a one-on-one question answer session with the students, and it's live where you can share your doubts, your views. Uh, you can you can solve whatever you want. We have MCQ polls here. We'll send you a poll where you can solve the questions. That's mostly in the format of FMG exams and next exams. Now, coming to express exam module, it's like a crash course where we cover entire syllabus in 20 hours just before your exam. So it's like a revision before your exam. So this is only beneficial if you join the live classes and if you see the recorded videos and you solve the polls and you sit for the mocks that we have, then only this will be beneficial. It's like a crash course. We also have a session where we clear one-to-one doubts with the students, anyone who's having any doubt. So it's a very student-centric approach that we give to the students. The students will have personalized attention to any topic that they are unclear about. So we cover here essential topics for the final exams, and we make sure that the student is prepared before going to the exam. Now, hard copy note sets are made by our experts who help you understand the way you should present the answer in the exam hall. So it's the concept and the questions extracted from the previous year question papers and laid down in a hard copy set notes. So you can use this notes to prepare for exams. It is made by very expert educators. Coming to the point of question bank. So we have three levels in the difficulty of question bank. We have beginners to expert level, where you can customize your question bank. It's an application where you can download on your mobile phone or on your tablet or your iPad anywhere. And we cover the MCQs for NEET PG, FMGs, and for academic exams as well. Practical sessions is where we train the students for their practical exams, how you should approach to the external examiner, uh, how you should answer the questions, what you can expect from an external, and all those things will be covered in practical session modules. Now we have a four subscription plans. First two, you will not have hard copy note sets and you will not have an advantage of clearing your doubts. But the last two, where you have complete learning plan and ultimate MBBS plan. Ultimate MBBS plan is for 4 years and complete learning plan is for 1 year. So you will have all the benefits in the last two plans. You can see it on your screens and you can use the code DR space NAWAL MOHAMMED 20 for discount on any subscription. Now let's start with the topic of the day. We have is complications of suppurative otitis media. So the complication of suppurative otitis media are usually and still frequently seen in India. So the causes are usually due to poor socioeconomic status, lack of education, unawareness about healthcare, especially unhygiene, and lack of availability of the trained specialists that we have in our system. Complications of suppurative otitis media is usually seen in India, not in places where we have sophisticated healthcare sector. Okay, so factors. So I'll just, before we dive into the topic of complications, I'll tell you the factors that will influence the development of complication. Okay, so because the examiner might ask you this in the external and in the practical. So factors, as I told you, age, socio-economic status, education, and hygiene. All right. So these are important factors. Other than this, we have conditions like cholesteatoma, where we have osteitis or granulation tissue in the chronic otitis media that will destroy the bone. So we had a class on the topic cholesteatoma. So cholesteatoma is also one of the important cholesteatoma. Okay, so cholesteatoma is also an important one of the risk factor where you can see complications of chronic suppurative otitis media. We have covered cholesteatoma in a detailed lecture. And we know that cholesteatoma destroys the bone and helps the infection to penetrate deeper into the middle ear and cause infection. Okay, so remember, apart from age, poor socioeconomic status, or social education, hygiene, cholesteatoma is an important risk factor. If it gets complicated, it will lead to complications of chronic suppurative otitis media. Now, how does the complication taken? What are the pathways that the spread of infection comes into play? Is either by direct bone erosion or by venous thrombophlebitis or by perforated pathways. So it's either that your bone is directly eroded, just like we said in cases of cholesteatoma or granulation tissue where the osteitis comes in and the bone gets eroded and it becomes more vulnerable to the organisms, or because of venous thrombophlebitis. Venous thrombophlebitis is chronic, actually, it is more common in spread of acute infections. So infection from the mastoid bone can cause thrombophlebitis of venous sinuses, and this will lead to furthermore infection in the complications. Okay, now the most important part is perforated pathways, where we say that perforation of tympanic membrane leads to infection of the middle ear. So it can be congenital condition, it can be due to petrosquamous suture, it might be because of any skull fracture, or maybe because of some surgery, post-surgical complications, or maybe because there is some defect in the oval or the round windows or any sort of infection. So just remember the pathways. There are three pathways, 1, 2, and 3. Pathway through infection, pathway through venous thrombophlebitis. Okay. And one more is perforated pathway. Okay, so perforated, again, it is divided into congenital, patent, post-surgical, over or around window defect, or any sort of infection. Now, you know the factors that can affect and complicate chronic suppurative otitis media. And also, you also know that the factors, the pathways from which the infection comes into the middle ear. Coming to classifications of complication of chronic suppurative otitis media. So there are two. One is intratemporal. You can see it on your screens. One is intratemporal and one is intracranial. So intratemporal is within the temporal bones. So where is your temporal bones? It's on both the sides. These are both temples, frontal, parietal, temple, right? So intratemporal means it is confined within the temporal bones. So here the structures that are related to temporal bones are usually involved in intratemporal complication of chronic suppurative otitis media. So what are the structures? Mastoid bones. So mastoiditis, inflammation of mastoid bone. The bone behind your ear is called mastoid bone. Petrositis, inflammation of petrous part of temporal bone. Okay, facial nerves will be involved. It leads to paralysis of facial nerve. Librinets will be involved. It will lead to inflammation of librinets. Okay, so this is intratemporal structures. Now, intracranial means inside the cranium, within the cranial wall. So here what will happen is you will have abscesses. So remember it like this: extradural abscess, subdural abscess, a brain abscess, subdural abscess. It will also affect your meninges because it's inside the cranial wall. So meningitis and otic hydrocephalus. Okay. So remember, intracranial will lead to abscesses. It is more complicated. And intratemporal is within your temporal bone. So the structures around your temporal bone will be involved. Mastoid, petrous part of temporal bone, librinet, facial nerve will be involved. It will lead to facial paralysis. Now, before diving into acute otitis media, I just want you all to know that there is a sequel of otitis media. There is a chain, there's a law, there's a rule of otitis media. They are because of direct result of middle ear infection, and you should be able to understand how it is different from the complications. So first of all, they include perforation of tympanic membrane. So you can write here sequel. I'll write it here, sequel of otitis media. Okay. So first of all, it is perforation of tympanic membrane. And then then your ossicular chains will be eroded. So this will lead to hearing loss, right? Then you will have adhesive otitis media. You will have tympanosclerosis. Cholesteatoma will be setting in, formation of cholesteatoma. Then you will have conductive deafness. Remember, cholesteatoma will lead to conductive deafness of hearing loss. This is because also your ossicular chains are eroded. Then if it becomes chronic, it will lead to sensory neural hearing loss. Then if it is in a child who's growing in age, then he will have speech impairment. And the child might also have learning disability. So I'll just write it down, just note it, so that you will have general knowledge. And maybe if examiner ranks you in the exam, you're able to answer him. He might ask you what is the sequel of otitis media. So it is perforation of tympanic membrane. All right, TM for tympanic membrane. Okay, you have ossicular chain erosions. Then what we have adhesive otitis media. Yes, and then we have tympanosclerosis. Now, when your tympanic membrane is involved, when you have tympanosclerosis, what will happen? Cholesteatoma will set in, right? Then you will have conductive deafness, conductive hearing loss. because your ossicular chains are not now involved. This will lead to sensory neural hearing loss, sensory neural hearing loss, SNLH. Okay, sensory neural hearing loss. Then you will have speech impairment. If it's a child, you will have speech impairment, followed by language impairment. Okay, so this is how it becomes. This is how the sequel is. There are 9 steps: perforation, ossicular chain erosion, adhesive, otitis media, tympanosclerosis, cholesteatoma, conductive deafness, sensory neural deafness, speech, and then the learning disability will go. The last 2 conditions are secondary to loss of hearing in developmental phase of infant and child. Remember this. So if it's an adult who's having complications of chronic suppurative otitis media, he already knows how to talk, right? So he will just have hearing loss. He will not have language or speech impairment. But if it is a child who still is in the age of grasping words and learning language, if he gets into the complications of otitis media, he will have speech impairment and learning disabilities. I have mentioned this in previous class also. The parents will come to you. This is very important for FMG students. The parents will come to you saying that my child is not talking, or maybe my child has uh, inability to speak early. They will just tell you that my child is late. He still did not develop his speech abilities or language abilities, or he does not respond to me, or he's not learning words. So you should not think he might have some psychiatric problem. The first thing as a doctor you should do is you should check his auditory system. You should get his auditory test done. And then you should rule out if he is having any otitis media. Usually it will be hearing problem. The child who is deficit of speech and language, they will usually have auditory problems. So if it is a speech or language barrier, you don't have to go for a psychiatric check. You have to go first for hearing abilities and then rule out if he is having other psychiatric problem, if that is fine. Okay. So this is some information for FMGs. Coming to the point of acute otitis media. This is an intratemporal complication of otitis media. Intratemporal. So here in today's class, I have only covered the important topics of complications of otitis media that will be asked in exam either from 4 mark or 2 mark or an essay. I have not covered all the complications because the class will go for like 3 hours or 4 hours if we dive in deep. So just to make it important, I have covered only the questions that will come in the exam. And those are important for practical exams, actually, not only for academic students, also for FMGs and also for people who are going to sit for next exam. So acute mastoiditis, it is an inflammation of mucosal lining of antrum and mastoid air cells. Okay. So what is acute mastoiditis? Inflammation of mucosal lining. Of what? Of antrum and mastoid air cells. Mucosal lining of antrum and mastoid air cells. This is very important. You should write the definition before you begin any topic that you present in the exam. So term mastoiditis actually is used when this infection spreads from mucosa to the mastoid air cells and will involve the bony walls of mastoid air cells. So mastoiditis is actually the infection that spreads from the mucosa and the mastoid air cells and will involve the bony walls of walls of the mastoid air cells. So the pathology of mastoiditis are actually 2. One is production of pus under tension. Other one is hyperemic decalcification and osteoclastic resorption of bones. Okay, so it's either because of the pus formation due to tension, or it's either due to hyperemic decalcification and osteoclastic resorption of bony walls. I repeat. So what will happen is that the inflammatory process will extend to mucoperiosteal lining of the air cells. Now remember that mastoid air cell system, they will have a lining called mucoperiosteal lining. I will write it down here. They will have a mucoperiosteal lining. Okay, so what will happen? This will furthermore increase the amount of pus, and then this pus will come out through a perforation of tympanic membrane or osteition tube, and it will not be able to control that infection. So the mucosa will become swollen, and mucosa of the antrum will also become swollen, and attic will also get involved, and the accumulation of pus will be there under the tension. Now, the process of hyperemic decalcification is actually engorgement of mucosa and dislocation of calcium from bony walls of mastoid air cells. So, hyperemic decalcification, it means the calcification it's becoming decalcified. So, it is an engorgement. So, mucosa will cause engorged. It will be engorged. So, when the mucosa will be engorged, it will causes dissolution of calcium. So calcium will be distributed from the bony walls of mastoid air cells. Okay, just remember it like that. Hyperemic decalcification means dissolution of calcium from the mucosa. Mucosa. Okay. Now, both these processes will lead to destruction. Remember it like that. Both these processes will lead to destruction. Now, pus might break through the mastoid and it will enter into periosteal area, and it will lead to abscess there, and it will lead to further complications and creation of fistula. So that's another story. But remember, there are two steps in pathology: production of pus under tension and hyperemic decalcification and osteoclastic resorption of bone walls. What happens in production of pus is that the inflammatory process from the mucoperiosteal lining of the air cells will increase the amount of pus, and that pus will drain either from the small perforation of tympanic membrane or in the osteition tube. Okay. Now, on the other side, the swollen mucosa of the antrum and attic will also impair the drainage system, and this will lead to accumulation of pus under tension. So from here, the osteition tube, and from here, the tympanic membrane. Both of these are causing tension in the middle ear, where the pus is starting to accumulate under tension. That's what it means. And in case of hyperemia, the engorgement of mucosa will cause dissolution of calcium from the bony walls of mastoid air cells. So that's why it is known as hyperemic decalcification. Both these processes of pathology are important because these both will lead to destruction. Okay, so you can see here in this picture very clearly that the patient is having inflammation of mastoid bone. It is known as mastoiditis. Can you see inflammation of the mastoid bone? Here you can see infection of mastoid. So first it is ear. Yeah. So important thing is the word mentioned here is ear turned forward. It means when you look at the child, if you see, let's say the child is having mastoiditis on the right side, as an ENT physician or as a general physician, if you see the child his left ear which is not infected, the earlobe will be normal. But if you see on the right side, his earlobe will be lifted up. That's because the mastoid bone will push the earlobe, the pinna of the ear ahead. Okay, so this is one important sign that you can say, one of the important clinical features to rule out if the patient is having any sort of mastoiditis or not. Okay, now clinical features of acute mastoiditis. So I have divided here as signs and symptoms. Both of these are clinical features. So coming to the part of symptoms, they are similar Just like how they are in acute suppurative otitis media, they will be same in cases of chronic suppurative otitis media and in case of mastocytitis. So the patient will have acute middle ear infection that will change in the character of the symptoms and is significant to develop acute mastocytitis. Okay, so the patient will have pain behind the ear, of course, because his mastoid bone will be infected. So pain behind the ear is also seen in cases of acute otitis media, but it will subside when the tympanic membrane perforates and the pus comes out, or either the patient is given antibiotics. Unlike this, in case of mastocytitis, it is persistent pain and it will increase in intensity and it will be more recurrent. So there are two different things. Pain behind the ear will be seen in acute suppurative otitis media and also will be seen in case of mastocytitis. But in case of acute suppurative otitis media, it either will subside because of perforation or with use of antibiotics. But here in case of mastocytitis, remember it is a complication. So it will be recurrent or it will increase in the intensity and the pain will be persistent. Okay. Now coming to the point of fever. So the patient will have fever. So fever, it is again persistent. It will be recurrent. Even after giving antibiotics, the patient will have a development of point mastocytitis. Okay. Now, ear discharge is the third symptom sign. So you can see that in mastocytitis, discharge becomes more profuse and it increases in the prudence. So in some cases, what will happen is that the discharge may cease due to obstruction and you might think that it has resolved. But any persistence of discharge beyond 3 weeks in case of otitis media, you should go back to the point of mastocytitis. So I'll write this point here, very important for FMGs again, and also for students who are going to sit who are going to sit for the practical exam. So if you see acute mastocytitis, let's say you have diagnosed a patient with acute mastocytitis. Okay, he's having pain behind the ear, he's having fever, and he's having ear discharge. Now, again, in the patient who's having acute mastocytitis, if the discharge remains or if the discharge is persistent, then you should rule out that it is mastocytitis if it is more than 3 weeks. So I will sum it up in this way that if acute otitis media has discharge beyond 3 weeks, then you should think of mastocytitis. Then it is a complicated condition. Okay. Now coming to other clinical features, the patient, of course, there is inflammation of mastoid bone. So the patient will have mastoid tenderness. It is a very important sign. It is an important sign. Okay. And the pain will be behind the ear at its tip. Okay. Tenderness will be suprameatal triangle. So patient will have referred pain also. And in cases of acute otitis media due to inflammation of mastoid antrum. So it can be seen in acute otitis media, but usually it will be more painful in cases of complications of chronic suppurative otitis media. So you should always compare it with the normal site. If it is more painful compared to the other side, then you can say, okay, the patient is having mastoid tenderness. Apart from that, we have again ear discharge that's coming in. So remember, the ear discharge will be mucopurulent or purulent. Okay, so I'll write it down here. Mucopurulent or purulent. So it can be mucopurulent or it can be purulent. Okay, maybe seen coming through central perforation of pars tensor. So remember the structure of tympanic membrane, right? Get this in here, right? So if there's a perforation here, it will come out through perforation. Okay. Now, sagging of posterior superior meatal wall. You can see here the third point is sagging of posterior superior meatal wall. Now, this is due to periositis of bony part between antrum and deeper part of posterior superior part of bony canal. So here it's a part of anatomy. Let's not dive into that. Just remember it. We'll have a different class for this. Just remember that it is due to periostitis of bony part between antrum and posterior superior part of the bony canal. So it is due to periostitis of bony wall between antrum and posterior superior wall. Okay, now perforation of tympanic membrane. Again, perforation of tympanic membrane. Usually it is a small perforation because it is a complication. Okay, perforation can sometimes appear just like a nipple, just like a pimple like protrusion, and it will not perforate. So remember, in case of mastocytitis, the perforation will either be small or it will either not perforate and cause a nipple like protrusion. And that's why you will have mastocytitis, because the pus will start accumulating under the pressure. Remember this word. So now swelling over mastoid, initially there is edema. Okay, then the patient will have obliterated and pinna is pushed forwards and downwards. This is the major sign. So when you will see over the swelling of mastoid, the patient will have, of course, they will have hearing loss. So it will be conductive deafness. Hearing loss, it is conductive. The examiner will ask you, what type of hearing loss will you see in case of mastoiditis? No, it is conductive deafness. In your academic exam, anywhere you see types of hearing loss, this condition will cause conductive deafness or this condition will cause sensory neural hearing loss. Please make a note of those, because in examining clinical findings, it is very important that you know which conditions will cause conductive deafness and which conditions will cause sensory neural hearing loss. Okay. Now, before this, we'll go for investigation. Now, how will you investigate these patients? You will do blood counts. You will check ESR, will of course raise, right? You will do an X-ray of mastoid bone and you will do ear swab if there is perforation for culture and sensitivity. Four things: ear swab, blood count, ESR, and X-ray of the mastoid. Complications of mastoiditis. What are the complications that you will see in patients of acute mastoiditis? You will see subperiosteal abscess. If the pus will end, it will have a reflux back. It will enter into the subperiosteal layer and it will lead to subperiosteal abscess. Number one. Number two, it will lead to inflammation of labyrinth. Number three, it will involve the facial nerve leading to facial paralysis, petrositis, extradural abscess, subdural abscess, meninges will be involved. The patient might have brain abscess. The patient will have lateral sinus thrombophlebitis and otic hydrocephalus. Now, students for FMGs should remember that patient who have a history of otitis media, let it be acute or let it be chronic otitis media. Okay. If they complain of early morning sickness along with vomiting, then you should think that the patient is having brain abscess. Now, these patients will also have very high fever. But the first sign of brain abscess is that the patient will tell you, as soon as I get up in the morning, I vomit. And if he is having history of any previous ear infection, then you can link it with the condition of brain abscess if he is having fever. Okay, then of course, then you have specific investigations that you should do, X-rays and CTs and all those things. But this is one hint that everyone should know. Now, important absent is Bizold abscess. Okay, so Bizold abscess is actually seen in patients with abscesses that is related to mastoid infection. So if your mastoid bone is infected, it will lead to many abscesses like post-auricular abscess. It will lead to zygomatic abscess, and one more important is Bizold abscess. Now, I remember the examiner external asking me what is Bizold abscess. So I have included in my be in your question banks and in your whatever guide books that you use for preparing for previous year's exam. So Bizold abscess is actually that occurs following acute mastoiditis. Okay, when pus breaks through a thin medial side of the mastoid and present at a swelling in the upper part of the neck. So remember that Bizold abscess is usually a complication that you will see in mastoiditis when the pus will break through the thin medial side of the tip of mastoid, and it will involve the upper part of the neck. So here what happens is that the abscess can be deep in sternocleidomastoid muscle. I just wrote here the clinical features. I'll write it down here. Some points of Bizold abscess. Bizold abscess. So it is because of acute mastoiditis. Okay, what will happen here? The pus will break through the medial side of tip of mastoid and present as a swelling in the upper part of the neck. So swelling in upper part of neck. Okay, so there are a few points that you should know. It will lie deep to sternocleidomastoid muscle. Now, why sternocleidomastoid muscle? Sternocleidomastoid muscle is related to the mastoid bone. Sternocleidomastoid muscle, right? Now, other point is that it might follow posterior belly of digastric. Okay. It will also lead it will also involve the angle of the jaw if it is posterior belly of digastric. Okay, I'll write it down here, angle of jaw. Now, the third point is that it can be seen in the posterior triangle. Where is posterior triangle? How many triangles do we have in the neck? So it is usually seen in posterior triangle. Okay. Posterior triangle of neck. And it will track down to carotid vessels also. So it might involve carotid vessels. Okay, now we'll go to clinical features. So clinical features is acute upper jugular lymphadenitis. Okay, abscess or mass in the lower part of parotid gland. As I told you, it might involve the angle of the jaw. So it will infect the parotid gland, of course. So there might be an abscess or a mass in the lower part of the parotid gland because it is also involving the angle of the jaw. Or the patient might have infected branchial cyst. Branchial cyst will be somewhere here in the posterior part of the neck, posterior triangle of the neck. The patient might have parapharyngeal abscess or jugular vein thrombosis. Okay, so all these points you should remember. Now, how do you treat Bizold abscess? So, treatment, or before that, remember that you do a CT scan. To rule out the patient is having Bizold abscess, you do a CT scan of mastoid and the neck. Okay, now treatment is cortical mastoidectomy, and you carefully explore the tip of the fistula that opens into the neck, if any. Okay, now if there is any fistula, you have to drain off the neck. If there is any abscess, by doing an incision and drainage, and then you should give a patient antibiotic. Now, antibiotics should be carefully given after culture and sensitivity. Okay, so this is all about Bizold abscess. I just remember this because I encountered this question by my external during my practical exam. It is one of the important complication of mastoiditis. Usually, it will be seen in your clinical practices also. Coming to the topic of non-suppurative otitis media. So non-suppurative otitis media, again, we have covered this topic before. Just to have a deeper understanding of what is non-suppurative otitis media. So non-suppurative otitis media is also known as glue ear. Remember, it is also known as otitis media without suppuration. So here, there are two pathogenesis that you should know. Number one is that there will be malfunctioning of the eustachian tube. And number two, the patient will have increased secretory activity. So there are two pathogenesis of glue ear, or we can say otitis media, or you can say secretory otitis media. There are a lot of names that we have for non-suppurative otitis media. Now, coming to the point of clinical features, the patient will have the disease that it will usually be seen in children of 5 to 8 years of age. Okay, so you will see glue ear in cases of children who are at age of 3 to 5 years, usually school-going children. You will see non-suppurative otitis media. Okay, the patient will have hearing loss. Now, this is usually a presenting symptoms, and sometimes it will only be the symptom that you will see in patients with otitis media with effusion. Other thing that you will see is that, again, I will tell you before I proceed, that the patient will have deafness that will be unnoticed by the parents. And it will only be discovered accidentally when the parents bring the child to the hospital or the clinic saying that my child is not able to talk, or maybe he has a delayed speech. Okay, so the patient will have hearing loss that might pass unnoticed by the parents, and it will be discovered accidentally when you do an audiometric screening test. Audiometric screening test. Okay. Now there will be an earache, which will be usually mild, and they will have this earache usually with the history of upper respiratory tract infections. So that's why we say they will have mild earaches, because they will have earaches only when they have upper respiratory tract infections. Now, the other thing is that you will see otoscopic findings in the patients. Number one is that the tympanic membrane is usually dull. And second is that it will be opaque. And the third point is that they will have loss of light reflex. So for one, it will be dull. It will be dull, opaque, with loss of light reflex. So this is an otoscopic finding that you will see in patients with otitis media with effusion. Now, it may appear yellow, or it may appear gray, or it may appear. The patients will also have thin leash of blood vessels along the handle of malleus. Okay, tympanic membrane will show varying degree of retraction. Sometimes it is very retracted, sometimes it will be mildly retracted, sometimes it will be slightly bulging, sometimes it will be fully bulged. Okay, the patients will have fluid level and air bubbles that you will see in thin tympanic membrane. So here you should remember that non-suppurative otitis media, first thing is that the tympanic membrane will become thin. Okay. Second is that you will see air bubbles in the thin tympanic membrane, and you will also see fluid levels. Now, this is an insidious condition. It is a very chronic condition that will be due to accumulation of non-purulent effusion. So it's, as I told you, it is known as secretory otitis media, or mucoid otitis media, or also known as blue ear. So non-suppurative otitis media, it is a chronic condition. Often the effusion can be thick, it can be viscid, okay, it can be thin, it can be serous. But usually the fluid is sterile. Remember this, usually seen in students, school-going children. Let's say it like this. So clinical features, hearing loss, delayed and defective speech, mild earaches, usually when the patient will encounter upper respiratory tract infection. And when you do an otoscopic finding, you will see a dull and opaque tympanic membrane with loss of light reflex. It can appear yellow, gray, or bluish in color because it is retracted. Okay, so we have a image here. You can see air fluid levels. You can see tympanic membrane is very thin. Right? Again, here you can see pars tensa. You can see retraction of tympanic membrane. It is bulged out. Right? Here you will see very nicely. You can see fluid levels and air bubbles in the tympanic membrane. Now, how do you treat the patients with otitis media or glue ear or non-suppurative otitis media? So the aim of treatment is usually to remove of the fluid and to prevent the reoccurrence, right? You have to make sure that you're removing the fluid out of the tympanic membrane, and you should make sure that the reoccurrence will not happen. So there are two ways you do it, either conservatively or with surgery. So conservative management means you give medications and you medically treat it. So there are certain antibiotics, decongestants, or anti-allergens that you can give. So antibiotics are usually useful in patients who are coming with glue ear plus upper respiratory tract infections, or in patients who have acute suppurative otitis media that is recurrent. Okay, so you can give them antibiotics in those cases, in complicated cases, and anti-allergic medications like antihistamines. We have cetirizine, levocetirizine. Sometimes you can combine them with steroids. Usually for the children who have allergies, you can give them along with steroids. Now, decongestants, topical decongestants, you can use them as a form of nasal drop or as a spray or as a systemic decongestant. Okay, so the main aim of decongestant is to relieve edema of the eustachian tube. The surgical part is that you do laryngotomy and aspiration of fluid. So you make an incision in the tympanic membrane and you aspirate the fluid. IND, incision and drainage, along with suction. So thick mucous membrane will require, if you do an IND and you see the mucus that is coming out of the tympanic membrane is thick, then you will have to install saline or mucolytic agent in order before you aspirate. So if you see that the mucus is thick, you have to either use saline or mucolytic agent to liquefy the mucus, let's say, so that you can aspirate it easily. Because it is thick, it will be very difficult to aspirate. So you have to dilute it. Let's say it in a very blunt manner. Sometimes there are two incisions made in tympanic membrane. If the mucus is thick, you will have to make two incisions. I have mentioned this in a previous class. Let's say this is your tympanic membrane. One incision is made anterior inferior and the other one is anterior superior. So this is anterior inferior. Okay, and somewhere here, anterior superior. It can be like this, it can be like this. Anyway. Okay, now the second point is that garment insertion. So you insert a garment if laryngotomy and aspiration along with medical measures have not helped. So now you did laryngotomy, you did aspiration. Even after putting the patient on antibiotics and giving him medical treatments, it did not help you. And the fluid will reoccur. And this actually happens in school-going children. Then you will have to insert a grommet. So grommet is to provide continued aeration to the middle ear so that you create a window and the pus is not accumulated, in fact, and it comes out. So it is left in that place for weeks or months and it will come out by itself. You do not have to reoperate the child and remove the grommet. It usually comes out by itself. Now, the third way you can do is tympanotomy or cortical mastoidectomy. Sometimes it is required for removal of thick fluid. Okay, or sometimes when the fluid is related to cholesterol granuloma, then you will have to do a tympanotomy or a cortical mastoidectomy. So either you will enter through the mastoid bone or you will have to do a tympanotomy. Surgical treatment for causative factor. Now, sometimes what happens is that the adenoids are responsible for this condition, blue ear. Sometimes tonsils are involved for this condition. So you will have, if it is an adenoid related condition, then you will have to do adenoidectomy. If it is tonsil related condition, then you will have to do a tonsillectomy. Okay. So actually adenoidectomy and tonsillectomy are done simultaneously when you do laryngotomy. So it's not like, let's say the patient is having adenoids and you're saying, okay, this is the reason that the patient is having glue ear, so you only remove adenoids. No, you don't have to do that. First of all, you will have to do laryngotomy and aspiration of fluid. Removing adenoids will not help the fluid to aspirate by itself. Of course, it is all connected to laryngotomy and aspiration. So first of all, you will have to do laryngotomy and aspiration of the fluid. And then if it is adenoids involved, you do adenoidectomy. If it is tonsil involved, then you do tonsillectomy. Okay, so this is all about the treatment of otitis media or glue ear or serous otitis media, or they say it as secretory otitis media, mucoid otitis media. Remember, it is a chronic condition where there is accumulation of non-purulent effusion. So it is non-suppurative otitis media, but it has fluid, right? So the students will confuse it like this. It is non-suppurative otitis media. It has fluid. It has fluid which is non-purulent. Okay, that's why it is known as non-suppurative otitis media, because it has fluid that is non-purulent. All right. So here you can see that we are inserting a grommet here in this picture. If you can see, right? This is the forceps from which we are installing a grommet. So this is all about otitis media, non-suppurative otitis media. Now, coming to the part of tubercular otitis media. So, tubercular otitis media is usually seen in patients who are having tuberculosis. Okay, so it is somewhere involved to the lung. The clinical features, of course, the patients will have clinical features of hearing loss. They will have perforation. They will have all these symptoms. But it is also known as tubercular otitis media. It is because the patients will have tuberculosis of the lung. That's why it is known as tubercular otitis media. So it is also a condition where you will see hearing loss, you will see perforation of tympanic membrane, you will see facial paralysis, the patient will have painless ear discharge. Now, how will you treat the patient with tubercular otitis media? Of course, you will have to treat the tuberculosis of the patient to treat tubercular otitis media. So in most cases, what happens is that this infection is secondary to pulmonary tuberculosis. So you will have to make sure that you treat the TB of the patient to treat tubercular otitis. Yeah. Sometimes it is blood-borne from tubercular focus. Sometimes it is seen in patients who work in laboratories. So it is sometimes blood-borne. Okay. Sometimes it infects within itself. From the blood, it will enter into the lungs. From the lungs to the blood, then to the ear, tonsils, cervical part, or mesenteric lymph nodes. So it is usually a blood-borne form of infection. Okay, blood-borne form of infection. Usually, it focuses lungs, tonsils, cervicals, or mesenteric lymph nodes. Now, clinical features is right in front of you, but what is the pathology? So it is usually very slow and insidious. Okay, slow, insidious. Now, patients will have middle ear cleft. So there you will see tubercles at the part of middle ear cleft. The patient will have painless necrosis of tympanic membrane. So you will also see necrosis of tympanic membrane. Okay, now you will also see multiple perforations of tympanic membrane, middle ear and mastoid will get involved. It will involve the bone and the ossicles. The patient will have facial paralysis, just like how we have symptoms here, facial paralysis, osteomyelitis, all those things will happen. Now, remember that the ear discharge is usually painless, but it will smell. The ear discharge will be foul smelling. Perforation, just like we spoke, perforation will be in past tense. It can be multiple, it can be two, three, or a lot. Like it will become like a sieve. It will have a lot of holes in it. Okay. Now here the hearing loss will be conductive type of hearing loss, or maybe sometimes the patient will have sensory neural hearing loss because of the involvement of librenet. Okay. So hearing loss can be conductive hearing loss, or it can be sensory neural hearing loss. Sensory neural hearing loss means librenet is also involved. Okay, facial paralysis because involvement of facial nerve. Now, how do you diagnose these patients? You'll have to do a culture of the ear to rule out if the patient is having tubercle bacilli. Okay, chest X-ray. Of course, we have to do if we think it's TB, but that's not the case. You will not find it out like that if you do. If the patient comes to you with otitis media, you cannot say, "Oh, you might have just TB," right? You will have to ask the patient about his history. Sometimes the patient will not tell you he is having uh, tuberculosis, right? So you will have to find out from his medical history, like what are his medications? Is he having any medications or not? And if he is having medications, maybe he'll have TB medications involved, right? So you will have to examine for granulations, and you will have to examine doing a chest X-ray to confirm if the patient is infected with tubercle bacilli. Now, treatment is anti-tubercular theory. Now, anti-tubercular therapy is usually for primary diseases. Okay, systemic anti-tubercular therapy you give it for primary diseases. Now, local therapy, what you can do is you can do ear toilet. Remember the word ear toilet for any ear condition where there is discharge. You will have to clear off the ear. So, oral toilet or ear toilet. Local treatment is ear toilet. Okay. Now, mastoid surgery is one more procedure that you can do. You can do it if there are complications related to tubercular otitis media. The complications are that the healing might be delayed. These patients are already immune low. So these patients will have delayed healing. The wound will break down again and again. These patients will have fistula formation. So in this case, you will have to do a reconstructive surgery of middle ear, and then you will have to, uh, you know, keep on reviewing those patients. So I'll just write it down that the patients might have fistula also in some cases. Now, you cannot do this surgery until you finish off with the anti-tubercular therapy. Remember, mastoid surgery in cases of tubercular otitis media cannot be done until anti-tubercular therapy has been completed. Now, here in a very sophisticated condition. I remember there was one patient who was having tubercular otitis media, and he did not inform the hospital that he was having the doctors that he was looking. The doctors who were looking at him that he had TB because the patient had this social stigma. Anyways, we decided that we'll do his mastoid surgery because he had infection. He had mastoiditis, and it created a fistula in his mastoid wall. So, anyways, we prepared him for the surgery. So, before surgery, you have PSA, post-surgical analysis, pre-surgical analysis, where you screen the patient before you take him to the OT. You check his heart, you check his lung, you check his breathing, you check all his systems before, and the anesthetist will declare him as fit before he is operated. Okay, so when we did a PSA, we found out that the patient had TB. So what we had to do is we had to delay the surgery, and we had to make sure that he finished his anti-tubercular therapy. And then after that, we operated him for tubercular otitis. So usually what happens is that you will not know if this otitis media is tubercular or non-tubercular. Okay. Sometimes the patient will not tell you the history, especially in places like India, the patients will not tell you complete history. They will disguise some of it. So you cannot confirm tubercular otitis media until you don't screen the patient completely, get his chest X-ray done, get his culture done, and take a thorough history of him. They will not inform you all these things. So this is all about tubercular otitis media. So see, you can see here multiple perforations in the tympanic membrane. The tympanic membrane is completely perforated in this patient. Now, what happens after this tympanic membrane is it's already perforated, the infection will enter through the tympanic membrane, these holes, and it will start infecting the labyrinth, the cochlea, then slowly the ossicular chains will be involved, and that's how they will have sensory neural hearing loss. Okay, now, safe and unsafe chronic suppurative otitis media. So what is chronic suppurative otitis media? This is what we had. We had a class the last time, suppurative otitis media, chronic suppurative otitis media. So there are two things, safe and unsafe chronic suppurative otitis media. So what does it mean by safe and what does it mean by unsafe chronic suppurative otitis media? So in case of safe suppurative otitis media, it is also known as tubotympanic otitis media. Okay, it is safe, or you can say it is a benign type. So it involves the anterior inferior part of the middle ear cleft. So now middle ear involves this. It has a cleft, right? So when the anterior inferior part of the middle ear cleft is involved, the eustachian tube, the mesotympanum, it will lead to a central perforation. And this condition is known as tubotympanic. So remember, it is a safe and a benign type of condition. It involves anterior inferior part of the middle ear cleft. And that is eustachian tube and mesotympanum, and usually leads to a central perforation. Now, very important point is that there are no risk of serious complications in patients with chronic suppurative otitis media, that is tubotympanic. So what is definition of chronic suppurative otitis media? Chronic suppurative otitis media is a long-standing infection either of a part or a whole of a middle ear cleft. Right? So these patients will have ear discharge, they will have a permanent perforation. So this is the definition of chronic suppurative otitis media. Now, if chronic suppurative otitis media is of tubotympanic type, it is safe and it is benign, and it usually involves the anterior inferior part of the middle ear cleft. Now, if it becomes, so you can see here, this is a diagram of anterior inferior part of chronic suppurative otitis media. Now, eticoantral, it is unsafe and it is dangerous type. Dangerous or unsafe type. Now, the tubotympanic part involves the anterior inferior, in front and low, आगे से नीचे, and anticoantral involves the posterior superior, from back up, posterior superior. So one is moving anterior inferior, let's say it's anterior inferior, and the other one is posterior superior. So moving posterior superior. Okay, anterior inferior, posterior superior. Okay, now it will involve active or marginal perforation, and this will lead to erosion of bone, In such conditions, we say it is cholesteatoma, where you see granulations, and these patients will have high risk of complications. Okay, so you can see risk of complications is high in this variety. What variety? In aticoantral part type of chronic suppurative otitis media. You can see here aticoantral posterior superior. Okay. Pathology of tubotympanic type. So pathology of tubotympanic type, since it is benign, it is localized to one part. Okay, it can be localized to mucosa and to anterior inferior part of the middle ear cleft. So what happens is actually the process of healing and destruction go hand in hand, and either of them may take an advantage over other. Either the healing will take advantage or the destruction will take advantage. So it will move simultaneously. There will be healing, there will be destruction. There will be healing, there will be destruction. Okay, so this is all about pathology of tubotympanic. Just to summarize, so there will be perforation of pars tensa. Usually, it will be central perforation. Remember, these words that I'm highlighting in the pink are very important. So, perforation of pars tensa in tubotympanic part is usually central perforation. Now, what happens to the middle ear mucosa? Either it will be normal or it will become edematous and velvety. So now if the disease is going healing and destruction. So if it is active, if disease is active, it becomes edematous and velvety. Okay. Now if the disease is inactive, it becomes normal when the disease is inactive. Okay. Now coming to the polyp part, usually a smooth, what is polyp? Polyp is like a smooth mass. It's like a flesh like a pendulum, fleshy pendulum type of thing. Okay. So it is a smooth mass of edematous and inflamed mucosa. If you can see here, mass of edematous and inflamed mucosa. This will protrude through the perforation and it will enter into the external canal. That's very extreme. The polyp will leave the perforated part of tympanic membrane and it will enter into the external canal. Now, what happens to the ossicular chains? Ossicular chains are usually intact and mobile, but they might show some degree of necrosis if there is perforation. Okay. Tympanosclerosis and fibrous adhesion. So, tympanosclerosis, it is because of calcification of subepithelial connective tissue. Okay, it is usually seen in tympanic membrane or in the mucosa of the middle ear. So you can see here that it's either the remnants of tympanic membrane or under the mucosa of the middle ear. So what happens in tympanosclerosis is that the patient will have white chalky deposit on the promontory or on the ossicles or on the joints of the ear or in the tendons and oval and round windows. Okay, so there will be a chalky white deposit on promontory, ossicles, joints, tendons, oval and round windows. So tympanosclerotic mass will sometimes affect the mobility of these structures and it can sometimes cause conductive deafness. Now, furthermore, what will happen is that now there will be fibrosis. So remember, fibrosis will usually be seen in healing. So if there is healing, there is fibrosis. Even when you have a cut on your hand, it will become like a scar, right? So that is fibrosed. And there's a healing part. Now, this is about tubotympanic. What you will have perforation of pars tensa, the middle ear mucosa. If the disease is active, it will become edematous and velvety. If it is inactive, it will be normal. There will be polyps sometimes that will exit through the perforated part of the tympanic membrane and sit in the external canal. Ossicular chains, sometimes they might show necrosis and the patient will have conductive type of deafness. Tympanosclerosis is one condition where you will see that there is white chalky deposit on the promontory, ossicles, oval, round windows, and the patient in the healing process, they will have fibrosis and adhesions. Now, coming to the part of pathology of aticoantral chronic suppurative otitis media. So in case of aticoantral type of chronic suppurative otitis media, the patient, number one, they will have cholesteatoma. Now, I'm not going to take a whole new class on the topic of cholesteatoma. You can go back to our previous video and you can watch the class of cholesteatoma where we have described in detail the pathology, the the etiology, the clinical features, treatment, diagnostic investigation, complications of cholesteatoma. Okay. The other part is osteitis and granulation tissues. Now, osteitis and granulation tissue, in this condition, what happens is that the mass of granulation will surround the area of osteitis, and they may fill the attic, the atrium, and the posterior part of tympanum. And usually the patient will have fleshy red polyps. So this is osteitis and granulation tissues. Coming to the part of ossicular necrosis, it is common in aticoantral disease. So ossicular necrosis is also seen in tubotympanic part, but in tubotympanic part, it is sometimes, not so severe. But in aticoantral type, where it is an unsafe type of chronic suppurative otitis media, you will see necrosis of ossicular chain. And what will happen is that the cholesteatoma will bridge the gap. And this will lead to destroyed ossicles and hearing loss. Okay. So ossicular necrosis. Now coming to cholesterol granuloma, it is the granulation tissue with foreign body. Okay. So you will see here cholesterol crystals. If you see it under microscope, cholesterol granuloma, you will see cholesterol crystals. So it is actually a reaction to a long-standing retention and secretion of hemorrhage, or, it is because of coexisting cholesteatoma. Let's say if the discharge is long-standing and it is tensed in the ear, it will lead to cholesterol granuloma. Okay. So this is all about the pathology of aticoantral chronic suppurative otitis media, cholesteatoma, osteitis, ossicular necrosis, and cholesterol granuloma. Now, this is one important table that all of you should know about chronic suppurative otitis media. Chronic suppurative otitis media can be without cholesteatoma or can be with cholesteatoma. Okay. Now, the condition without cholesteatoma, you will have two stages. It's either a wet perforation or a dry perforation. Now, if it is a wet perforation, how do you treat? You will do an ear toilet, right? Just the start. So you will do an ear toilet. You will use an antimicrobial drug. You will, if it is very severe, you can use systemic antimicrobials. And you should make sure that the patient is taking precautions. Now, what are the precautions? You should ask the patient not to swim and to avoid water and all those conditions. Now, if it is a persistent discharge, even after you treat the patient, then you will have to do a tympanostomy without mastoidectomy. If mastoid is involved, then you have to do mastoidectomy. If mastoid is not involved, then you will have to do only tympanoplasty. So tympanoplasty without mastoidectomy. Now, coming to the part of dry perforation. If it is a dry perforation, you don't have to treat it conservatively. You will straight have to do a laryngoplasty or tympanoplasty. Okay. So now you have one twist here. That let's say if a patient is having wet perforation, you treated him conservatively, right? Now he is having persistent discharge after that. Then you have to do a surgical procedure. Now, sometimes what happens is that if you treat a wet perforation, it will become a dry perforation. If you treat a wet perforation conservatively, it might become a dry perforation. So if it becomes a dry perforation, you will have to do a laryngoplasty or a tympanoplasty. Okay. And patients with cholesteatoma, straight away, you have to do a surgery. Now, surgery is what? Canal wall up procedure or canal wall down procedure. Now, what is canal wall up procedure and canal wall down procedure is what we took a class before this in case of cholesteatoma. I want you all to go to that video and see what is cholesteatoma and what is canal wall up and canal wall down procedure. I hope this is enough information for the topic, and follow us on our platforms. Yes. Take care. Thank you.